Good morning everyone. My today's topic is about Dentigerous cyst. Now before that we should know the definition of cyst. It is a pathologic cavity or sac having fluid, semi-fluid or gaseous contents and not created by the accumulation of pus. It is sometimes, not always, lined by epithelium. So this is altogether the definition of cyst. Now if we are considering the definition of dentigerous cyst, it goes something like an odontogenic cyst that surrounds the crown of the impacted tooth caused by fluid accumulation between the reduced enamel epithelium and the enamel surface, resulting in a cyst in which the crown is located within the lumen. Now to clearly understand what is lumen, lining and wall, this diagrammatic representation is quite helpful. Now coming to the total percentage of occurrence of a dentigerous cyst among all the odontogenic cysts. Now if we are considering about occurrence of the cyst in the oral cavity, then periapical or radicular cyst is the most often. But if it is of odontogenic origin, then dentigerous cyst is mostly common. About 21% among all the odontogenic cysts, dentigerous cyst occurs commonly. Now coming to the introduction, dentigerous cyst is the second most common form of odontogenic cysts after radicular cyst. As I mentioned, radicular cyst is the most common, that is a periapical cyst, but it is of inflammatory origin. If we are considering the odontogenic origin, just after the radicular cyst, dentigerous cyst is common. Thought to be developmental in origin, dentigerous cyst is caused by an anomaly in the reduced enamel epithelium. Dentigerous cyst is formed by the force exerted by the exudate that accumulates between the reduced dental epithelium or reduced enamel epithelium as we call and the tooth crown. So it is a fluid accumulation between these two layers. It is generally related to a partially ruptured or impacted tooth. So dentigerous cyst is always or generally associated with an impacted tooth or partially ruptured tooth. So this is a key feature of identifying a cyst if it is radiologically you are seeing. But that too, it sometimes will have some diagnostic dilemma, and that we will come later. Now pathogenesis. What is the pathogenesis of dentigerous cyst? Dentigerous cysts arise as a result of cystic change in the remnants of the enamel organ after enamel formation is complete. So, after completion of the enamel formation only, if the cystic changes is happening, it results in the dentigerous cyst. They enclose the crown of an unerupted tooth and are attached to the cemento-enamel junction. So, this is a key feature. On gross macroscopic feature, sometimes if we are seeing from the cervix to cervix that cyst is attached, we will generally understand it is a dentigerous cyst. So it will be attached to the cemento-enamel junction. They develop by expansion of the follicle when fluid collects or space is created between the reduced enamel epithelium surrounds the developing tooth and degenerates as a tooth is erupting. In the formation of a dentigerous cyst, fluid accumulation occurs when the erupting tooth compresses the tooth follicle. It compresses the tooth follicle and obstructs the venous outflow, which induces the serum to cross through the capillary walls and forms a cyst. In this photo, you can find out. Just like this only the dentigerous cyst happens. Now clinical features. Age. It's generally in 20 to 40 years of age, this is an age range, but affected in the young people, 20 to 40 years, young to middle age we will find. Whenever there is an impacted tooth underneath, there is high probability for some people it will come to dentigerous cyst. But it rarely affects the children because impaction in children is very less. Sites, it is most commonly seen in the third molars of the mandible. Other common locations are third molar teeth of the maxilla, maxillary canines, premolars of both the jaw bones. Now, rarely dentigerous cysts are also associated with supernumerary tooth. They can be caused by an impacted supernumerary tooth localized in the anterior maxilla, and it accounts for only 5.5% of all the dentigerous cyst cases, and those that spread with the maxillary sinus are even more infrequent. Now, what are the syndromes associated? Mainly two syndromes we will see associated with dentigerous cyst. One is the cleidocranial dysplasia, another is Maito-Glamy syndrome. Now, clinical features. Though they are aggressive, but asymptomatic except for the cases where there is infection or expansion. So, it is mostly found out accidentally in routine radiography. It's not always symptomatic. Patients rarely comes with the symptoms of swollen jaw or pain having dentigerous cyst. So it is accidentally mentioned in finding. In the event of infections, if it is secondarily infected, that time it will be painful and causes swelling also. So in that time, it can have symptoms, but generally, dentigerous cyst, if it is small in size, doesn't have any enlargement or the expansion of the jaws, it won't come with symptoms. Pus may discharge in case of secondary infection. Radio discovered on radiographic examination can cause cortical plex expansion. Dentigerous cyst can cause facial asymmetry and precipitate a destruction of the adjacent tissue. So it is destructive, it is aggressive, but in initial stage it does not cause any symptoms. Failure of eruption or displacement of adjacent roots. See, sometimes because of dentigerous cyst also sometimes tooth couldn't erupt. So if you are finding the tooth past its age not erupting, we should take a radiograph and see what is happening inside. What are the causes for that tooth not to erupt? Now, cystic content. It consists of yellowish fluid in which cholesterol crystals may be present. See, normally cholesterol crystals is a pathogenic feature of radicular cyst, but in sometimes in dentigerous cyst also it can be present. If it is secondary infected, it will be present. In case of long-standing infection, purulent pus may be present. Now, radiological features, it is a well-defined radiolucent area. Unilocular or multilocular radiolucency encircle the crown of unerupted tooth. Radiologically, the dental follicle may expand around the impacted tooth in three variations. So, in three variations, you will see that expansion. First will be circumferential. By the name itself, we are finding circumference surrounding the tooth. Second, lateral. Lateral will be any one of the side will be tilted. It will be expanded till one side. And coronal or central. Here we are finding one OPGE where we are seeing a dentigerous cyst. It is encircling the tooth. The root we are finding not well developed because it is not yet developed. It's on the verge of developing, so we are not seeing any root of the tooth, but it is encircling the crown of the tooth. Now the types I mentioned, we can see in this radiograph and also in the image how the central type, the lateral type and circumferential type will look. Coming to the differential diagnosis, there will be very differential diagnosis. First important differential diagnosis of OKC can be dentigerous cyst can be OKC. Why OKC? Because sometimes OKC also occurs in relation to unerupted tooth. So that time the dilemma can occur. Second, hypoplastic follicle. Adenomatoid odontogenic tumor. Sometimes if it is occurring in the canine on the anterior region of the maxilla, we will have the diagnostic dilemma with the AOT in radiography. So histopathology is very important to rule out these lesions. Calcified odontogenic is same, and radiculosis. Obviously, if it is around the apex of the root or the lateral side, sometimes we will radiologically it will mimic the radicular cyst also. So that case also we have for the histopathology is very essential to rule out the dentigerous with some other similar looking cysts. Coming to the histological features, cyst is always attached to the neck, that is CEJ, cemento-enamel junction of the tooth. How will be the epithelium? Non-keratinized, very thin, reduced enamel epithelium. It will look exactly like reduced enamel epithelium. So it will be very thin, only 2 to 3 cell layer thick. Connective tissue will be fibrous, but it is also will look like the dental follicle. Rarely mucous metaplasia of the lining you will find out. It will be rare. Now, somewhat like this, the dentigerous cyst looks. Just how the thin layer it can be seen. Just look at how the thin layer it can be seen. See the connective tissue, how it is. It's looking like a dental follicle. It's like embryologic origin. So like this only will be the dentigerous cyst. Now coming to the treatment. It can be treated by one of the following methods. Careful enucleation of the cyst plus unerupted tooth. If it is possible not to save the tooth, we have to enucleate with the tooth. Marsupialization. If it is a large cyst, we can undergo marsupialization. A combination of both the procedures also we can do. And sometimes it can recur. If it is incomplete removal of the tooth, sometimes it can recur. Now, what are the complications? Now, certain complications are there if it is pertaining. First is there can be neoplastic transformation of the cyst into ameloblastoma. Second can be neoplastic transformation into squamous cell carcinoma, but it is very rare. Intraosseous mucoepidermal carcinoma also develop from the mucus lines. If it is undergoing mucus metaplasia, from that mucous epidermal carcinoma also it can develop. Then recurrence due to incomplete surgical removal. As I mentioned before, incomplete surgical removal can result in recurrence. Fifth is permanent bone deformation or pathological fracture. So sometimes it's not like every time dentigerous cyst will lead to these all complications. Sometimes it may lead. So thank you. Hope these small presentations will help you in any way. Thank you so much for the patience listening.